One of the things I think we bring to our interactions with OHTs and our other partners is that it's really a collaborative approach where the partners set the agenda. So if you have a need, if you have an interest, if you have a question, we're there to help. We can bring our expertise and our knowledge, but you are the context experts, and we're there to assist in any way that we can. Uh, Diana mentioned rather that we build capacity within the organizations. A part of that, our role rather is to help with that, and we're quite nimble in terms of what we're able to do. At the very basic level, we provide data analytical support. So this is framework development. It could be data collection and extraction, analyses that are targeted to the specific questions that you might have, and then shared interpretation. I think this is crucial. We could bring our expertise as sort of data experts and information and research and evaluation experts, but the context is something that the local OHTs and other experts need to provide, and that's where the shared interpretation comes in. We can help with regional coordination of data requests because the care that is provided isn't just in the local hospitals or primary care organizations, it's throughout the province, and there is interflow and interconnection not only of the patients but the data. So we can help with that and again help provide some of the local context or help with the interpretation from a local perspective. And then, of course, it relates to what do you do with that? Well, not only are you going to look at the programs that you're implementing and seeing whether they're working or not working, but what can you use that towards any strategic planning and responding within the ministry requirements and OH requirements, but also within the requirements of the various agencies that make up your OHT. Our direct work with OHTs for a few years now. I mean, as Diana mentioned, the center's been in existence since 1992, and we've had a long and successful history with working with folks in the north. And since 2020, basically soon after the OHTs were announced, we've been providing support at various levels within that. You've got to do the work, but you've also got to share it. So we're big on sharing the work. That basically runs the gamut of formal reports, formal presentations to informal discussions and consultations and policy briefings and email blurbs and whatever is needed to communicate the findings and communicate the importance and the interpretation therein. So just some examples there. Uh, we've looked at basic things like the demographics of the attributed populations and the resident population. We know that OHTs are premised on the attributed population, but we also recognize that there are catchment areas. Folks still have a fairly strong geographic perspective when they talk about patient care and patient services. And so there's some overlap, obviously, between the people who are part of the OHT and live in your area, but or are part of the OHT and don't live in your area and may be closer to some other location, some other OHT. So there are some differences and similarities there that are important to consider when you're thinking about planning and also when you're thinking about evaluating the data, evaluating the program using the available data. We look at attached, unattached, and what a colleague of mine has called loosely attached patients. So by that, we mean that within the attributed population, you have a rostered group, which is pretty strongly attached to primary care. That's about 80% of the population, and I'm rounding things here, as you can appreciate. Approximately 10% in addition to that are what folks have been calling, or my colleagues have been calling loosely attached. And that's really those that are either virtually rostered, which doesn't mean virtual care, but it means that they're seeing primary care physicians for their care and going to those locations for their care. Their children in the area, they're going to CHCs. It's that group that are not formally rostered, but are basically attributed to the population. And in the old frame sense of the word, there's a lot of those folks are unattached. They're not, by virtue of the definition, they're not rostered. So it's important to understand some of those differences. And what do we look at? Well, there's a couple examples here that follow, or more than a couple there. We're looking at emergency department visits by CTAS score. We're looking at some of the social economic characteristics of the populations, again, attributed in resident populations, mental health addiction, x-rays, that kind of stuff. Who's using it? Where are they going? Where could they go? That kind of thing. And I think what's important, particularly for some of the larger areas, not only in terms of larger geographies, but larger patient populations, is, are there differences within those groups? Are there community-specific differences? Is one community more inclined to do this or less inclined to do that, or has a greater number of patients who perhaps have diabetes or a lower percentage, and so forth and so on? So we recognize that within OHTs, uh, there's the attributed population, there's the resident population, and within the resident population and the mix of the two, or the combination of the two rather, there are some differences again by geography that are important to pay attention to, or at least look for to see whether they are important. As a center, we advocate for basic patient-oriented care and facilitate evaluation and research and CQI in the context of a learning health system approach. But what does that really mean from the perspective of a OHT? So what it really means, at least from my understanding, is that with a learning health system approach, that Craner works with OHTs to more fully integrate practice with evidence gathering, analysis, and interpretation, right? And what that enables is a collective approach, a collaborative approach that is responsive to the needs and circumstance and provides the tools, the data analytic tools, the interpretation tools, the framework tools to help OHTs achieve their mission objectives. So that's really, what this boils down to. So you can see the contact information there. I should clarify something that we didn't clarify earlier, and I apologize for that, is that Craner actually has two sites. So we have a sister site in Lakehead University in Thunder Bay. We're based in Laurentian. We work with each other on a variety of projects and will collaborate as need be. But the stuff that I'm speaking to you today is really about the work that we've been doing here at Craner Laurentian. Thank you very much for your time and attention.